Greetings and welcome to this module on human immunodeficiency virus, its approach, diagnostics, and management. We sequentially go through this human immunodeficiency virus and AIDS in two module parts. So after this video, you will never worry about HIV management, and it is an approach for practicing physicians. It's completely for educational purposes. This is medicine beyond Harrison's. Let's get started. So HIV/AIDS, what physician must know in 2024? It was a very rampant disease during the 2000s up to 2010. Then the very good government programs have come up with NACO in place, and the disease prevalence have been constantly decreasing. So now it was first detected in 1981. First case was in Los Angeles. Then in 1983, virus was identified, named in 1986. The first ART was approved in 1985. Then finally, and during 2030, it is the goal to end AIDS threat. So progress it is now reduced new infections by 59%, reduced AIDS-related deaths by almost 69%. ART is now very affordable, effective, and less toxic. It is now become a chronic manageable disease rather than a very fatal disease during the 2000s. So why is it important for all physicians? HIV is a great mimicker. So once a patient is having HIV, he may present with just weight loss. He may present with just lymphadenopathy. He may present with just isolated splenomegaly, or even may present with meningitis. So it is very important to screen for HIV when the clinical condition is appropriate. So more than 30% of people with HIV were missed during their prior healthcare visits. So try to do a serological analysis to detect HIV 1 and 2 antigen uh, whenever the patient comes to the hospital if clinically indicated. So when to suspect HIV? So suspicion of HIV needs to be there, and the physician should understand that when to suspect an HIV infection so that they will do the appropriate clinical testing. So it is often missed. 50% of the acute HIV syndrome is missed. So it will present just like a flu syndrome soon after infection and just goes for a long asymptomatic phase. This long asymptomatic phase lasts for up to 5 to 8 years, and the CD4 count gradually declines, where then you will start having opportunistic infections. So CD4 gradually declines while opportunistic infections increases during the course of the 5 to 8 years. So major symptoms if presenting acutely is fever, night sweats. There can be just isolated cough with shortness of breath. There may be generalized lymphadenopathy, skin lesions of non-specific skin lesions, genital ulcerations, weight loss, diarrhea, oropharyngeal lesions, abscess ulcers, neurological signs and symptoms. Anything can be the presentation of a human immunodeficiency virus. So common symptoms is weight loss for more than 10% in last 1 month is a very important indicator and needs a serological analysis for HIV. Chronic diarrhea for more than 1 month, always check for HIV. Prolonged fever for more than 1 month, whatever be the cause, do a serology. Uh, Pulmonary infections with recurrent pneumonia, pulmonary and extrapulmonary tuberculosis, always root HIV. For oropharyngeal candidiasis and esophageal candidiasis, if a patient is presenting with oral thrush, always do a serology. So specific indicators, meningitis, especially fungal cryptococcal meningitis, toxoplasmosis, CMV retinitis, recurrent herpes zoster, molluscum contagiosum. These are AIDS defining illnesses. So if a patient is having these kinds of illnesses, always do a serology, have high index of suspicion when no response to routine treatment or unexplained illnesses. So whenever you see a molluscum contagiosum or recurrent herpes zoster or toxoplasmosis or fungal meningitis, think of HIV. So these are the clinical stages of human immunodeficiency virus and its presentations. So initially stage 1 it is just with persistent generalized lymphadenopathy. Only that or mostly it will be asymptomatic also. So stage 2 it becomes more advanced where there will be moderate weight loss of less than 10 kg of presumed or measured body weight. There will be recurrent respiratory tract infection with sinusitis. Even a sinusitis is it could be due to HIV infection. Recurrent tonsillitis, recurrent otitis media, recurrent pharyngitis. All these recurrences are less than 1 year. If there is more number of occurrences of sinusitis, tonsillitis, otitis media, upper respiratory manifestations, it can be HIV. Recurrent herpes zoster, angular cheilitis. Just an angular cheilitis, the patient may present with HIV patient may present with just angular cheilitis. There will be recurrent oral ulcerations, papular pleuritic lesions, seborrheic dermatitis. Whenever a patient is having dandruff and those dandruff causing seborrheic dermatitis, uh, so it is basically due to fungal infection. Always think of HIV. Fungal nail infections that is not resolving. So always think of human immunodeficiency virus. So stage 3, more advanced stage, happens around the asymptomatic stage of around more than 8 years. At that time, there will be unexplained severe weight loss, more than 10%, unexplained chronic diarrhea for longer than 1 month, unexplained persistent fever, persistent oral candidiasis, oral hairy leukoplakia, pulmonary tuberculosis, severe bacterial infections with pneumonia, empyema, pyomyositis, bone joint infections, meningitis, bacteremia, acute necrotizing, ulcerative stomatitis, gingivitis, periodontitis, even anemia, just an unexplained anemia of less than 8, neutropenia or chronic thrombocytopenia are all age-defining illnesses. So this is the last and final stage of HIV infections, where there will be HIV wasting syndrome, pneumocystis pneumonia, recurrent severe bacterial pneumonia, chronic herpes simplex infections such as orolabial, genital, anorectal of more than 1 month's duration, esophageal candidiasis of even can expand into the trachea, bronchi, or lungs, extrapulmonary tuberculosis, Kaposi's sarcoma, cytomegalovirus retinitis, CNS toxoplasmosis, HIV, encephalopathy, extrapulmonary cryptococcus, including meningitis, disseminated NTM, progressive multifocal leukoencephalopathy caused by JC virus, chronic cryptosporidiosis, chronic isosporiasis. All these parasites are age-defining illnesses. So, disseminated mycosis, recurrent septicemia, including non-salmonella typhoidal salmonella. Typhoidal salmonella is not considered to be an age-defining illness, but non-salmonella typhoidal salmonella is a part of age-depending illness. Lymphoma with cerebral or B cell, invasive cervical carcinoma, atypical disseminated leishmaniasis, symptomatic HIV-associated nephropathy, or symptomatic HIV-associated cardiomyopathy. So all these are age-defining illnesses. So NEET test needs for diagnosis. Always do a two-step, three-step test. One is the rapid test, just to rule out if there is an HIV or not. If the test is negative, then it's high probability that the HIV is not present, which is having high sensitivity. ELISA test also having high sensitivity. To confirm, use it with the other two second and third rapid antibody testing. So Western blot was previously used for confirmation. Now it is not recommended by the WHO. So confirm positive reports as soon as possible. So to prevent loss of follow-up, there is a rule of three called ensure blood sample tested with three different antigen-based tests sequentially, such that to rule in HIV. Before giving a positive HIV report, there is a need to run three tests, and three tests should be positive. The counseling is essential, meaning of HIV positive result, the treatment options and availability, the long-term ART efficacy. All these needs to be counseled for the patients adequately to prevent loss of follow-up, prevent spread of infections to others. So this is a basic diagnostic algorithm. We do a A1 test, which is usually a very sensitive test, or either rapid diagnostic test or ELISA. If it is negative, then report HIV negative. If it is positive, perform the second test, which can be again a rapid test or ELISA. If it is both are positive, then again perform a third test. If all the three are positive, report as HIV positive. If either one is not positive, then report HIV single inclusive retest in 14 days. If A2 itself is negative, again repeat A1. If it is again A2 is negative, then report HIV negative. If A1 is positive, again repeat A1 is positive. Repeat HIV is inconclusive, retest in 14 days. So this is the algorithm. So it should be that all these three tests should be positive to report a patient to be having HIV. So management steps, it is defined as clinically classified into general management, treat opportunistic infections, chemoprophylaxis, initiation of antiretroviral therapy. So always maintain a good mental health. All these patients go in for depression on knowing an HIV infection is positive or AIDS illness is positive. So ensure them they are in a good counseling and follow-up protocol. Then psychosocial support is important. Adequate counseling sessions, screen for other opportunistic infections, provide chemoprophylaxis whenever necessary. So patient discussion, they should be counsel regarding and adopting a good and willingness and readiness for antiretroviral therapy, and saying that HIV is controllable completely and make the disease go into remission and can live a long life with a good mental support. So always educate about the potential side effects and give a full follow-up and monitoring plan to ensure loss of follow-up. So always screen for tuberculosis once you diagnose an HIV. The patient is having fever, weight loss, cough, or night sweats. Do a tuberculosis testing. There is persistent symptoms like headache, poor concentration, seizures, shortness of breath. Also, in the assess the history once you diagnose an HIV infection. Look for other comorbidities like diabetes, hypertension, and manage it accordingly. Usage of contraceptives should be encouraged. TB and HIV in family should be asked for. Risk behavior such as multiple partners, injecting drug abuse should be asked for. Substance abuse like alcohol, tobacco, IV drugs needs to be asked, and the other psychosocial history pertaining to the possibility of HIV infection should be asked. So check for the weight, BMI, weight, hydration status, pulse, respiratory rate, temperature, pallor icterus, oral cavity for ulcers, pore hygiene, leukoplakia, candidiasis, skin for papules, herpes zoster, molluscum, lymph nodes and the sites, size, consistency. If there is matting, then look for tuberculosis. Look for serious murmurs, signs of failure, RS for breath sounds and added sounds and other probable pneumonia infections, CNS focal deficits and cognitive status, abdomen look for hepatosplenomegaly, genitals look for ulcers or any other discharges. So always do this basic laboratory tests before starting the patient on ART. In an HIV positive patients, do a basic blood counts, complete blood count, fasting blood sugar, urea creatinine, serum bilirubin, ALT. CD4 count is must before starting a patient on ART. Baseline CD4 count is measured, then it is followed up. Urine protein and microscopic evaluation, chest X-ray is done, cervical pap smear is done in woman to screen. So additional tests if necessary, directly investigations for specific opportunistic infections based on the clinical profile, TB screening if symptomatic, anal pap smear in male sex workers. So these liver function tests, especially for hepatitis B and C co-infections can be there. Viral hepatitis markers are to be done. Then metabolic lipid profile, then VDRL for sexual health, advanced disease such as fundus examination to look for toxoplasmosis, cytomegalovirus infections if the CD4 count is low. For the CD4 count will come around. So surface examination, check for the lymph nodes, check site consistency mating, look for papules, zoster, scars on the skin, assess the full nutritional assessment and ensure adequate good diet during the treatment of ART. So signs of pneumonia and tuberculosis should be elicited into the respiratory system, CNS for past seizures and concentration issues, abdomen for hepatosplenomegaly. CD4 count, this is the one most important takeaway slide on here from this video. So the basic idea is to remember is more the decrease in CD4 count, more rarer infections come around. So when the CD4 count is more than 400 also, you can expect a viral infection that's with herpes zoster. So, but less than 350, you can expect tuberculosis. So, less than 250, common fungal infection starts happening to occur, with the first being oral candidiasis. If it is less than 200, expect pneumocystis pneumonia and esophageal candidiasis, tracheal candidiasis, aspergillosis. All these infections. And if there is less than 100, now you expect parasites such as toxoplasmosis and cryptococcus. So now less than 50, this is where things get complicated with the very, very rare fungal or Mycobacterium avium complex infections or progressive multifocal leukoencephalopathy by JC virus, cytomegalovirus. All this happens at less than 50. So based on this, we need to give coverage to cover opportunistic infections when the patient's CD4 count is less than low, less than these levels. So important guidelines. Nowadays, the guidelines suggest treat all policy. It's not based on the CD4 count. Previously, if the CD4 count is less than 500, the antiretroviral therapy is given. Now it's just that viral infection if present, then start treating for ART. So CD4 count is not required. Useful mainly for differentiating early versus advanced disease. It guides opportunistic infection, prophylactic decisions. The basal viral load is not required. Previously, it was required to know the viral load. Then now the most important guideline is do not delay ART initiation when in an HIV positive patient. So together we can end AIDS. So in this, we hope you learned about the early suspicion, the correct diagnostic methodology, and the rapid assessment before starting the treatment. This is the part 1 module of HIV infections. We will continue this in the part 2 of HIV, where we discuss about the treatment, other opportunistic infections treatment, and the other clinical aspects of HIV management. So this is Medicine Beyond Harrison's. Thanks for watching.